Thank you very much for the kind introduction, and it's nice to be here again on the same course, so the organizers haven't got tired of me. Well, my talk is actually, I'm going to reflect a little bit with what Ian mentioned. Of course, Ian, thank you for asking me to chair the steering committee. It's really a great pleasure to be with you. The organizers wanted me to look at novel interventions in PPH management. So we are really talking about what Ian was mentioning. We are doing this for publications, not for good health. But I can show you that even these small trials mean something for the good health. So before I start, I should really acknowledge Professor Sue Ellen Miller, who was actually working closely with me in FIGO, who presented this material in a different format. And I got a lot of slides from her, and Professor Andrew Weeks, who was here, who gave some, and Peter von Dodelson, he's the head of the department at St. George's now after I retired. So I got some from him, and Andrew Shannon, of course, Ian Roberts. I just got one slide just because you heard a lot, but just to recap on, so I would like to acknowledge. Declaration of interest, of course, I have area of research in PPH. I'm advisor to some of the companies and give lectures organized by companies, and also research collaboration with Ladal, which is a company itself. So when I looked at novel interventions, there are a few in terms of monitoring a patient. We know when the woman sort of bleeds, we look at the estimation of blood loss. We look at the pulse and the blood pressure. And recently, there have been possibility of looking at the pulse divided by the systolic blood pressure, which is called the shock index. Normal people, it's 0.5 to 0.7. And in normal patients, surgical patients, if it increases by 0.3, then they are more likely to get transfusion. Usually after 30% blood loss, this tends to increase. And when there is hypoperfusion of tissues, if we haven't really given enough fluids and blood, there is peripheral metabolic acidosis, which can be measured by lactate. Normally, you must have a full circulating blood volume and a hemoglobin of 7 grams to avoid the patient getting enough, or for the patient to get enough oxygen. So when you are using cannulas, in the UK, we use orange or gray cannulas. The orange is 14 gauge, which can deliver 240 mils of fluid per minute, and gray, which is 16, you can deliver 180 ml. So in the labor wards in the UK, we ask them not to keep anything other than the orange and the gray cannula, because it's quite important to deliver the fluid. If you don't deliver, metabolic acidosis will set in, and they will get lactic acidosis. And many women come up, and then they suddenly collapse after 1 hour because of severe acidosis. So I think measurement of lactate we have been ignoring, but it's something worth looking at. And it has been shown that whether you measure venous, arterial, or capillary lactate, there's not much of a difference, so you can really go by that. So, and pulse oximetry, especially if there's hypoperfusion, and there are methods of measuring. Then in terms of medication, when I looked at the literature, the drugs which are coming into vogue is heat-stable oxytocin, which is carbetocin, or duratocin we call it. It's a large study which is about to be launched as a pilot study. And of course, tranexamic acid, the woman trial. Maybe these two drugs will come into. And devices, you heard about anti-shock garment. There is a demonstration today. Suction devices, you have heard Dr. Panikar today, and another company in the States did some trial which I was involved in. I'll talk about that. And butterfly devices, Andrew will demonstrate this afternoon. And distant transport using drones might be something which we have to really look at as a possible future. Now, the reason I'm focusing on this is actually, this is a study which was done by the WHO and published in the Lancet, where they looked at 314,000 women in different countries, 29 countries, and they looked at whether the WHO recommendation of life-saving interventions was given, like antibiotics for cesarean section, sepsis, antibiotics, magnesium sulfate for preeclampsia, eclampsia, and also oxytocic drugs, whether they were given or not. And when you look at this, they divided the countries into low maternal mortality, moderate maternal, high maternal, and very high maternal mortality rates. And significant numbers, 62,000, 91,000, 122,000. And when they looked at that, if they look at the therapeutic prophylactic oxytocin here, nearly 80–90% were fully covered. So they all had prophylactic oxytocin, therapeutic oxytocin 81, and in fact, almost similar in all the countries. Magnesium sulfate, same magnitude. Antibiotics for cesarean, antibiotics for sepsis. But all countries were giving all this. But when it comes to death at the bottom, the low maternal mortality is 0, moderate is 49, high maternal mortality 169, very high 268. So there seems to be an increase. So where did they go wrong, having done all the essential obstetric interventions? So I went to some of the individual country results. This is actually from Pakistan, and it was published in April 2013. And I just want you to look at these figures. In that institute, they had 13,000 deliveries, and 187 of them developed severe postpartum hemorrhage. Now, of the 187, 93% got oxytocin as prophylaxis. They had therapeutic, as you can see, so these are all postpartum cases. So these are treatment oxytocics, nearly 93%, and misoprostol in addition, ergometrine, etc. But still, there were 13 maternal deaths. It's quite high, 113 out of 187. The only thing I could find is actually maybe they could have used more balloon tamponage before the clotting deficiency starts, because any of these conservative measures will not work if coagulopathy sets in. So once she has gone up to 30 to 40% blood loss, it starts coagulopathy. You can put a balloon in. Unless you correct the coagulopathy, it won't stop, or the brace sutures, because mechanism is actually, the natural mechanism is to contract the uterus, the blood clots in the uterine vessels. So whether you apply bimanual compression, use oxytocic drugs, put a compression suture, the mechanism is the same. And of course, tranexamic acid stabilizes the blood clot, which is already formed. So something is going wrong, and we have to improve on this, because in many countries like Sudan or Ethiopia, Nigeria, many of the deliveries are happening in the periphery where they don't have facilities. So it's quite important that we can think of something to help these countries and to improve. So let us look at monitoring of the patient. Estimation of blood loss is quite important, but it is important in relation to the blood volume of the woman, and the blood volume can vary depending on the body weight. The second is actually the shock index, which I'll show you some slides, and the pulse oximetry. Now, vital sign blood loss is not a reliable predictor, and the pulse and blood pressure, if you take it individually, the blood pressure might slightly drop, the pulse might go up a little bit, and you can use modified early warning obstetric charts, and you might be able to pick it up a little bit better, but nevertheless it won't give for that individual patient, because that individual patient, her systolic and the diastolic pressure might be on the lower edge. So for them, they won't reach the early warning obstetric score chart. So that is why it is quite important to look at other circulatory changes. So a more sensitive predictor of adverse outcomes, that is shock index. Now, the vital sign, when we talk about the total blood loss in terms of body weight, the last confidential inquiry into maternal death said calculate the blood volume by multiplying the kilograms in 100. We used to use 80, but they say easier to do 100, because if a 48 kilogram woman comes in labor, her blood volume is 4.8. So if she loses 1.6, she has lost 30%. But if she's a 72 kilogram woman, if she loses 1.6 liters, it's nothing. She will smile and say, thank you very much. So it's quite important. And the women who are small-made are also likely to have low hemoglobin, especially if they are from the African and the Asian subcontinent. So they have a low hemoglobin, a low blood volume, they bleed, and you're saying, oh, so much blood loss, but she's shocked. So that's why it's becoming important that we really keep an eye on a body weight, but also use sense of the blood pressure and pulse measurement, pulse over systolic blood pressure. This is actually the EMBRACE report asking you to calculate the blood volume and the 15%, 30%. So For a 50-kilogram woman, if she loses 1.5 liters, it's a problem. But if she is a 70-kilogram, then it's not an issue. She can lose up to 2 liters before she runs into difficulties. This is a chart produced by Sarah Patterson-Brown from Queen Charlotte. It's a useful chart, and we used to laminate it and put it in the tea room and the back of the door of the bathroom toilets in the labor ward. So when they have nothing else, they are looking at it and they have some idea what is happening, essentially to show that if there is blood on the floor, then that means she has lost more than 2 liters and the whole bed is soaked more than 1 liter. Now, this is one of the papers published from St. George's, which we looked at the shock index. And Tony, who is one of the anesthetists, and Ed Wynn, they did quite a lot of analysis with the statistician. And they showed that for the pregnant mother, the obstetric shock index is 0.7 to 0.9 compared to non-pregnant patient, who is 0.5 to 0.7. And the people who got the blood transfusion and who had difficulties are where the shock index changed by about 0.3. So if it increased by 0.3, I call it a rule of 30. The hematocrit drops by 30, pulse rate goes up by 30, absolute respiratory rate go by 30 is easy, things are going wrong. And this was published somewhere in 2013, as you can see here. And Andy Shannon and his group published this in 2015. They had a similar type of outcome in postpartum hemorrhage. But Andy was very entrepreneurial in some way. So what he decided to do, looking at this, is he produced a blood pressure machine. Because the automatic blood pressure machines normally records the systolic and the diastolic blood pressure and the pulse. So the parameters you want to measure is already there, but nobody is calculating the shock index. So if you put a small formula into that, it'll tell you there's a shock index. And if it changes, then it'll flash the red light. So this is actually his algorithm. If it is severe shock, it is red light will flash with the arrow down saying blood pressure. And the same machine can be used for hypertensive disease as well, because his interest was in hypertensive disease. And if it is more than, red flash and it'll go up. So you know what is happening, and yellow flash and so on and so forth. So it is not been evaluated clinically in shock patients, but it seems to be of some use in the future. And severe hypertensive disease, what we are worried is there is an auto-regulation on the blood pressure. And if it goes to beyond 170, then that property is lost, and arterial dilate and cause hyperperfusion, then the posterior reversible encephalopathy, and finally a bleed. So it is useful for both, so I'm just going to show that. It is only $19, but I bought it for 20 pounds. So maybe the price hike has come in. But nevertheless, for 20 pounds, it's fully worth it. And something which one could use it, and WHO has recommended. They have looked at it as well, because they can look for hypertensive diseases as well as shock. It can be used very robustly. And these are the indicators. And Sue Ellen Miller, I've showed the first slide, has worked, because she has worked with the what they call the anti-shock or the life wrap thing. And she has shown that it is a predictor of the outcome in some of the patients she has looked after. This is a pulse oximeter. If you go into Google or to the Amazon, you can buy a pulse oximeter for $20 or 20 pounds. But this one is connected to the phone, so you can actually transmit the pulse rate and the oxygen saturation at distant places, and also keep a record of it. So if you want to do some research, this can be done. And it's about $50. It's developed by Peter von Dodelson and his wife Laura Maggie, who are at St. George's now. And this can be done. So I first checked myself to see where I'm okay, or 99%. The pulse rate is a bit high. And it has been shown in hypertensive disease to be very valuable. And they say that if the oxygen saturation falls below 93%, then there is a problem. And it has to be evaluated in hemorrhagic situations as well. And I mentioned about lactate. This has been used in labor, but you can have a handheld machine to see for lactic acidosis. If you want to use the standard blood gas analyzer, you have to put a separate module, and you need a little bit more blood to get it done. So that is about evaluation. Now coming to drugs, carbetocin is a structural analog of human oxytocin. It's a long-acting drug. The effect is actually, it's 8 times longer than the standard oxytocin. In other words, it keeps the uterus contracted for a longer time, and as mentioned, 90% or 80 to 90% atonic uterus, so it keeps it contracted, so the blood can clot. It gives more time. And similarly, when you're applying bimanual compression, we tell them don't take the hand out for 8 to 9 minutes. Because if you take every 2 to 3 minutes, you will continue to bleed. So you have to keep it contracted. And that is what the duratocin or the carbetocin does. And the long half-life is 4 times that of the standard oxytocin. It has a similar safety profile. It's a simple and one single dose. So if I put it in a table form, the oxytocin is faster acting, less than 1 minute. It takes carbetocin 1.5 minutes. And 8 minutes, the duration of rhythmic contraction. This goes up to 60 minutes. So that means it can keep it contained, and also you don't have to think about prostaglandin, which does the same thing. And there are a number of studies. I'm showing individual studies, and that shows that it's a carbetocin compared to oxytocin. There's a reduction of major blood loss, more than 500 mils, and reduces the need for additional uterotonic drugs, nearly half, so you don't have to give another drug. And is longer time, because it keeps it contracted, at least she doesn't bleed for a long time before if she's going to bleed, compared to oxytocin, she tends to bleed much earlier. And the chances that you had to give an additional oxytocin become less. And this is comparing to, earlier was syntocinon, now comparing it to synthometrine. Oxytocin and ergometrine put together, again, carbetocin seems to be having less blood loss, more than 500 ml compared to the combination of drugs, and also less additional oxytocin compared to a combination of oxytocin and ergometrine. And the Bristol group has looked at various parameters, and they looked at also about analgesia after pain on day 1, day 2, day 3, and so on and so forth. And that also seems, because they have uterine contractions, which is painful, that is less with carbetocin. And compared to oxytocin, most of the side effects are almost similar, so there's no difference in terms of side effects. Now, in the theater, usually after a cesarean section, we tend to observe for women for bleeding for 2 hours. Sometimes they bleed a little, you keep them for some more time. Again, from the Bristol group in Southmead Hospital, they have looked at the timing. How long does the patient wait with carbetocin compared to syntocinon? And you can significantly reduce the number of women who are going to wait in the recovery with carbetocin compared to the oxytocin. So you're buying more time, and your theater turnover is much better with that. This is from the Cochrane 2012. Maybe there will be a later analysis, but looking at it is more effective than oxytocin and associated with less blood loss compared to synthometrine, and significantly fewer adverse effects. And incidence of hypertension is lower with carbetocin, because hypo and hypertension can be a problem. Syntocinon, if you give it bolus, it can cause severe hypotension, so you have to give it very slowly. And ergometrine gives hypertension. So those side effects are not there. So there's a trial called the Champion trial, sponsored by the WHO. It's just started as a small trial. They tried to recruit more patients, but we don't know the results yet as to whether it is going to come in. And my thoughts actually, at the moment, in many of these countries, they are using a combination. Syntocinon they give, and if it bleeds, they give misoprostol. Even in the UK, people tend to do that. And FIGO recommends 600 micrograms if there is no oxytocin available orally for prevention, and 800 micrograms sublingually because of rapid absorption. Maybe in the future, it might be carbetocin, if she bleeds, might have tranexamic acid. So it might be 2 drugs, and you have a sustained contraction, and whatever blood is clotting in the vessels, you stabilize it. And that might help quite a lot in the poor countries where they don't have surgical facilities of putting balloons and compression suture and so on. So I heard a lot about the woman trial. So we are waiting till June this year to see what the results are. And I think it's quite exciting times to see whether it can change the whole thing. Now, this is Sewell and Miller's work called the anti-shock garment. And this is actually, you start wrapping from the leg and then the thigh, then just over the pelvis, and there's a rugby ball-like structure. You wrap it on, and it squeezes the blood. Even when the woman has no pulse or blood pressure, when you put it on, the pulse comes back because you squeeze the blood back. And this compression on the tummy itself might stop the bleeding or reduce the bleeding, and it's very cheap, and it can be washable, and it can be reused again. So that is something, and especially for standalone midwifery unit and home deliveries, it might be something worthwhile having, so that, and even if you're going to transfer them to the theater in the hospital setup, it might be okay. Now, at St. George's, we were doing some study on a simplified version of the anti-shock garment, which we published in the International Journal. It doesn't seem to have given much results, so we are really trying to improve the design. The only difference is actually there's a wedge here which goes just underneath the uterus, above the symphysis pubis, and stabilize the uterus. And there is a little bit more of a wedge which pushes on the fundus to stop the bleeding. So there are some studies going on in Sri Lanka at the moment. Now this is actually Andrew Week's one, which he invented. We use bimanual compression. Sometimes it is really cumbersome, and if you had to transport the patient in a compressed form, it'll be difficult. So he divides the butterfly device, which looks like that, and you will have a real look and feel it and so on this afternoon. And that is how it is inserted, and once it is inserted, that is how it looks like. So it's something which is worthwhile to look at. Now there are other treatments which are available. As you know, a condom tied to a catheter is well known. It's used in India, Bangladesh, Sri Lanka, and so on. And there are different types of balloons used, and now they are trying to have a reservoir which can squeeze the fluid into the balloon, which is produced by path, and also having something effervescent substance. So the carbon dioxide comes in, and there's particles which can be disseminated with the carbon dioxide particles to go into the uterine surface and make it clot. And I think Vasudeva Panikka showed about the suction device. There's another model here which I'll show you. And finally about what is the role of the drones nowadays. So ESM uterine balloon tamponade. This is actually by Thomas Burke. It says every second matters. That's all, ESM, every second matters. First, when I read the paper, I thought, what is this ESM business? And uterine balloon tamponade. And what he did was actually nothing more than what the other people had done, but he puts everything in a package, a few condoms, a catheter, some ties to tie the balloon on, and then how do you put it in an instruction package, and a syringe with one Leo lock. And he published this material and in the British Journal last year, and he showed it was very effective. So it's actually seems to be is much better than people trying to go for condom here and the thread here. Just put everything together and package it. And their paper says that they could train people in 3 hours' time to really do it on a regular fashion. And they could do it without a speculum, because you can just do a vaginal examination and pass the Foley's catheter tied to the condom through. And this is actually by path, so they have a reservoir bag, and the same idea. There's nothing new, but rather than going for another saline bottle and so on, you can. And you can also have a gravity-fed mechanism, which is popular in Russia, for example. They put the balloon and keep a canister up and down, and when the uterus contracts, the level in the canister tends to go up. But no new ideas. But now this is actually about thromboxane, thrombin, uterine balloon tamponade. So it is actually using calcium carbonate and thromboxane and thrombin, which is propelled onto the vessels there and causes clotting. But again, this is something new which we have to really see how it sort of comes to, and still it needs intervention of putting something inside the uterine cavity. Now, at the same time, Vasudeva sent me a paper, and surprisingly, I was working with another group, and he beat us to that by publishing it. So we were fiddling with that and trying to develop the design, and the design is very straightforward. There's a loop-like thing which is very soft, and there are a number of holes to create a suction. And there's a balloon here which you can push it against the cervix to really cause the closed space. But Vasudeva tells me that it's not necessary. As you know, when you do a suction termination of pregnancy, you can see the uterus collapses and you can feel the grating noise. And I believe that that might be the case. So we had 10 patients which we recruited in Jakarta, and I wanted them to send me a film. And hemorrhage was controlled within 2 minutes with suction. And this is the distal loop, and there's occlusion balloon, and you apply the, this is to inflate the balloon, and this is to apply. So this is actually submitted to the Green Journal, is awaiting publication. This is how it looked like, and as you could see, balloon is put in, and the uterus automatically, because there is a closed space, you don't have to go very far. Once you go in, then you suck it, and then the whole uterus collapses. But we have to do more trials in this. I don't think you can depend on 10 cases, because the effect has to be felt that 85% of the times it works in 10 people's hand rather than working 100% of the time in one person's hand. So that is the real key. So we're trying to sort of make, and this is actually Vasudev Panik as the senior author who has published this in 2014. So we are about a year behind time, but we will catch up with him at some stage. What about the drone? Drone, I think, is quite like delivering with a stroke baby. You have mobile devices now where a midwife or doctor can text into a center here as to what they need. They can have a set of drones, and they can decide what they need in terms of solutions or bloods and so on. They might be able to deliver. And that is being tried now, not in postpartum hemorrhage, but in other conditions, how this can be. So in concluding, I think there are innovations now on the horizon, not that it is going to be. And in terms of triage and trying to find out the condition of the patient, maybe the shock index might come into more use with the phone pulse oximeter and the lactate measurement. Medications, we are awaiting the trial of woman trial, and the carboprost or the durotocin trial. Anti-shock garment is very useful. Abdominal compression belt and butterfly device, and Andrew tells me the trial is starting tomorrow because he's here today, so he can't put it on anybody. So we wish him all the best with this new device. The in-press suction device, we are trying to do it in different countries now. And the other low-cost ones are the do-it-yourself condom path and the uterine balloon tamponade. The thromboxane model is actually not very much used, but again had to be, and the drones, which can help us in the future. Now this picture is of Taj Mahal, of the queen who died following postpartum hemorrhage. The reason I'm doing is actually to show that this is actually symbolic of postpartum hemorrhage, the Taj Mahal, but also to point that this picture is taken from a drone because it's difficult to take a picture. So now you can take world over sending a drone and taking pictures. So thank you very much for the patient listening.